Thank you both for a wonderful presentation. This is always a difficult area. I suppose practice makes perfect. Understanding the anatomy is a key. And although the champions make it look so easy, they have many miles of practice behind them. So for the participants, you will have to practice this. I hope you take home the message that these are hopefully a very experienced practitioner showing you this, but this is certainly, hopefully, will stimulate your interest in this area. While I give Dr. Shibata a breather, a question for you, Philip, from Tony in Hong Kong. He says, when it comes to pudendal neuralgia, the effects of local anesthetic steroid injections can be short-lived and not often very long in terms of clinical efficacy. Do you have any advice in terms of prolonging the duration or making these test blocks more efficacious?
A good question. So I just want you, or everyone who asks this question, just step back, just think out of the box. What are we treating? So the treatment strategy is very similar to carpal tunnel. It's an entrapment neuropathy. So will injection work for carpal tunnel? Yes. Does it work for all? No. When you have a moderate to severe compression, is injection a good technique? No. It's supposed to have a surgical decompression, just like spinal stenosis. When you have a severe spinal stenosis, you keep injecting the patient. Is it a good thing? If the patient is not a surgical candidate, probably yes. But theoretically, when there's a nerve entrapment, you better do the surgery. So then we are dealing with the spectrum. Now, then you understand what spectrum we are dealing with. We are dealing with a mild to moderate spectrum of patient who will deal with the symptomatic management. So I would say for this group, I would say the local anesthetic steroid, usually it works fairly well. I do a series of 3 injections. Then they will have probably maybe a few months. I usually repeat the second series in the second half of the year. Now, how do I know it's severe or not? Well, when they have some severe positive symptom and start to have some negative symptoms, be aware. And if you have a surgical expertise, I will actually have them to consider surgical. And a lot of time we do a lot, and by the time we refer to surgery, the surgeon tell me it's so squished that you don't see any vessel over there. Is it a good idea to delay all this treatment? So if you have expertise, I would certainly think that like carpal tunnel, surgical may be a better treatment. But in the early part, yes, steroid and local anesthetic, and some of the people can use hydrodissection. So patient selection is important. And knowing what is our role as an injection is also important.
That's very well put, Philip. A question for you, Dr. Shibata. Is there a role for radio frequency of the maxillary and the mandibular nerve? Have you any experience, and are they useful in indicated patients?
As for mandibular nerve block, we can provide RF or PRF for the chronic pain patient. But as for maxillary nerve block, it's difficult to touch the maxillary nerve and using ultrasound alone. We have to combine the fluoroscopy. Okay.
Yes, I think that's a good message, that ultrasound in these difficult areas, ultrasound alone is not enough. You have to combine it as dual guidance with the traditional fluoroscopy. Another question for you, Philip, is from Fatima Zakaria. This is your day, Fatima. For entrapment neuropathy, will hydrodissection with D5W be effective?
So
unrelated.
It's possible. Just like actually, I'm using the carpal tunnel as example. Carpal tunnel have local anesthetic steroid, and also the literature compare local anesthetic steroid with hydrodissection. They have more or less the same in terms of efficacy. So it's possible, but I just haven't had those experience. I tend to inject local anesthetic steroid. But so Manoj, may I take this opportunity to ask Dr. Shibata just one question or comment?
Absolutely. Yes, please go ahead.
I find the infra and supraorbital nerve, I see the foramen, I do the injection. But if you think about the anatomical basis, the canal to the nerve ratio, so that means the nerve to the canal is more than 50%. So it's not a really sizable canal to the nerve ratio. So in the past, I find the foramen, I get excited, I put the needle in the foramen. But my question is, do we really need to put the needle in the foramen at all? Why not I see the foramen, then that means the nerve is there, I put it just outside the foramen, instead of just go inside and risk the needle trauma. So I would like to see what you think about this.
Yeah. In some case, we can see any foramen and any notch. In that case, I just infiltrate a local anesthetic along the near the point that pass through the 2 point that pass through the sagittal line 2.5 centimeter lateral to the midline. So I provide the RF and PRF. Yeah.
Mm-hmm. Okay, another question for you, Dr. Shibata. There's a lot of questions for you. This is from Rashmin Shanghani. How would you block the lingual nerve for somebody, say, undergoing cancer of the tongue? If they are 2/3 of the anterior 2/3 of the tongue cancer, is it possible to do a lingual nerve block?
So that means she will try to the lingual nerve only.
Yes, for post-operative analgesia, I suppose.
To tell the truth, I think it's impossible, but we can do a inferior alveolar nerve block under ultrasound guidance. This technique is just put the probe just above the mandibular notch at this level. Okay, then inject a local anesthetic on the external surface of the lateral pterygoid muscles. Then inject, and then the local anesthetic spread the inferior alveolar nerve, long buccal nerve, and lingual nerves.
Okay.
It's a terminal branch block.
Yeah, sure. Philip, another question for you by Dr. Yuvraj Koti. Do you recommend Botox injection in piriformis syndrome if patient shows good response to diagnostic block with local anesthetics and steroids?
Interesting question. So again, I always want people to do injection and think deeply. What is your role? Now, first of all, when we do a lot of peripheral nerve, we have a diagnostic block and therapeutic procedure. I get it. When we do it for the muscle, we have a clear-cut diagnostic therapeutic relationship like in the nerve. When you inject local anesthetic into the muscle, you shock the muscle just for a while. Does it mean that actually the therapeutic relationship will be the same? That I don't think that is a very direct answer for that. Nerve is different. You numb the nerve, you interrupt the signal compared with the more permanent procedure. That is a compared diagnostic and therapeutic. But for muscle, our challenge is a diagnostic. There's a strict relationship. And so if I think the patient with a good clinical suspicion of piriformis, I probably just actually, I would say 99% of the situation, I would say I inject Botox. So I am actually using this as diagnostic and therapeutic. So for that part, the first part of the question I answer, the second part I also answer.
Okay, thank you. I hope that answers your question. Here's another question for you, Dr. Shibata. It's from Muthukumar Rajagopalan. He asked the question, are there any indications, or if there is, what is the indication for maxillary and mandibular nerve blocks for post-operative pain management?
So I think oral and maxillofacial surgery. Yeah, it's a good indication. The maxillary and mandibular nerve blocks indicated for this operation. And if we use a high concentration of ropivacaine, and it provides a long duration.
So the question is, somebody else asked, when you do these maxillary and mandibular blocks, what concentration and what volumes of local anesthetic do you use?
Yeah. In the pain clinic, I inject 1 to 2 ml of 0.75% ropivacaine. But in the operation room, the oral surgery is very long. So I inject 5 to 8 ml of 0.75% ropivacaine.
And how long analgesia would you anticipate that, sir?
Maybe I didn't check the duration, but I often ask the oral surgeon, and they answered the patient didn't feel pain post-operatively, and they can reduce the analgesics.
Okay. Here's another question for you, Philip, by Dr. Udishmita Barua. She asked the question, sir, can you describe the pudendal nerve block in the frog position with ultrasound-guided imaging?
Say that again? I don't understand.
Sir, can you describe the pudendal nerve block in the frog position using ultrasound guidance?
Okay, so when you perform the ultrasound guided pudendal injection, it's a transgluteal approach. So there's a free approach for pudendal nerve. You can have a transvaginal approach, which you use a trumpet needle. I don't do that. You can do a transgluteal approach in the prone position, where you can see the interspinous ligament plane and also the alcohol canal. So there's a transgluteal. So everything that I described in ultrasound is transgluteal. That's transperineal, or actually from below, it's more a landmark guided technique, and the with or without the nerve stimulator. And I think it is actually quite painful, and also you don't see much. So I will just say my answer is I only do the transgluteal approach, not the transperineal approach.
Okay, there's one more question for Dr. Shibata. I think the question is, for the infraorbital nerve block, can it be done with the probe placed in the transverse orientation? And if it is, are there any complications to be expected in the oral cavity?
Sorry, I can't follow you once again.
Okay. Can you perform infraorbital nerve block using the transverse imaging? Yeah. Secondly, if you do, then are there any complications you need to expect within the oral cavity?
Oral cavity.
Inside the oral cavity or in the oral cavity?
According to first, I will answer the first question. I never use the transverse image for the infraorbital nerve block because in that case, maybe I think she will do an out-of-plane approach with in that case, there is a risk of eye injury. Out-of-plane approach, we can not always detect the needle tip, and we insert a needle deeper beyond the ultrasound beam. So I never use a transverse image for the infraorbital nerve block. And maybe the second question is about greater Palatin canal approach. According to my experience, I have not seen the complication, but maybe I think there is a risk of vascular injection. And before I started to this approach, I worry about a nerve injury, greater palatine nerve injury, but I have never experienced this complication.
Thank you, Dr. Shibata. Thank you, Philip. It's been a wonderful session. I'm sure the registrants and participants have truly gained a lot from your insights and the way you make them all very simple. I also take this opportunity to thank Monica Minolta and in particular Isa-san for his contribution and for having supported this event. I cannot be more grateful to you all. Also, a special thanks to all the previous speakers who are probably not here anymore. If they are, my gratitude to you. And for the participants, once again, remember that once the event is over, we hope to, with the consent of the speakers, have these presentation uploaded onto the university site or onto a site where you can access them. So don't be worried about it. But it's important that all of you register, because these access will be given only to registered participants of this meeting. So if you haven't registered, it's a simple 2-step. So just go and register yourself. Dr. Shibata, once again, thank you. You've traveled a long way from Nagoya to Japan. I hope you can take the bullet train back tonight or maybe tomorrow. So please stay safe and healthy, and hopefully we will see you soon. And you too, Philip. Take care, stay healthy, and love to your family. Take care. Okay, adios, everybody. See you all next webinar in 2 weeks' time. Take care. Signing off from Hong Kong. Bye-bye.
Bye.